enthusiasm is contagious. And if you need proof of that, tune into today's video. Well, hello and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam. I've been living with multiple sclerosis for almost 40 years. I've been hearing from some of you about this Pipe 307, a new therapy for remyelination in multiple sclerosis, and I have been pretty excited about that because I had seen a video that Dr. Brandon Bieber had published recently that was incredibly positive about this new treatment. So I'm going to show you that video today, almost in its entirety, not all of it, because I want to make it worth your while to go out and click on the link that I put below so that you can watch the whole video. But after that, I went out looking on the internet to find a few other interesting tidbits for you. So sit back and get ready. I'll just play a few things for you and we'll talk through them a bit and see if you end up sharing in this contagious enthusiasm.
Many have long dreamed of a treatment that could regrow myelin, the fatty sheath of nerve fibers, and it might be here. Today, I'll explain Pipe 307, a putative remyelinating drug that could treat diseases like multiple sclerosis. On the right of your screen are oligodendrocytes, the cells that form myelin in the central nervous system. And like all cells, they come from stem cells, which form oligodendrocyte precursor cells, which then through complicated signaling differentiate into adult oligodendrocytes, which form myelin. And they can remyelinate after injury, and that's part of the reason people with MS sometimes make prodigious recovery, but it doesn't always work perfectly. And this appears to be part of the pathogenesis of MS and why some people acquire disabilities over time. In this famous study by legendary neuropathologist Dr. Bruce Trapp, he looked at people with advanced progressive multiple sclerosis, and on autopsy within the multiple sclerosis plaques, oligodendrocyte precursor cells were abundant. However, they did not differentiate into mature oligodendrocytes and form myelin, and no one knows why. One theory is there's something about the local milieu of the multiple sclerosis plaques that prevents this, and even in 2002, when this article was published, people dreamed of how they might activate these cells. Many years later, Dr. Jonah Chan, pictured to the left, discovered clemastine. He's a researcher at University of California, San Francisco, and he designed an ingenious screen of existing FDA-approved drugs to see if, by chance, some of them could have remyelinating activity, and he found clemastine and other similar drugs. Now, this is an old, cheap, generic antihistamine drug, kind of similar to Benadryl. It's not really used anymore to treat allergies. We just have better, less sedating drugs, but it is available, trade name Tavist. It was patented in 1960, so it's very old, and it turns out its remyelinating effect has nothing to do with its effect on the histamine receptor. Rather, its effect on the muscarinic receptor is what's causing the remyelinating effect, and other similar drugs like benztropine also has a more modest effect. I first saw Dr. Chan give a presentation about this research in 2013, 11 years ago, and even then he fantasized about improving this drug, making it more potent, more selective, have less side effects. And sure enough, as you'll see in a moment, that has come to fruition. But in the interim, more research was done on clemastine. This is a study in animals, in experimental autoimmune encephalomyelitis, a rat model of multiple sclerosis. Rats were either given vehicle, i.e. placebo, the black dots, or clemastine in red. On the left is the EAE score, a clinical score. Higher score means more disability. And you can see rats receiving clemastine were less disabled on average, though it was not a huge effect. The research continued in humans. This is the REBUILD trial. Principal investigator Dr. Ari Green, also at University of California, San Francisco. I remember talking to him at a conference many years ago, and he was very cautious, reminding people that this is an unproven treatment. They studied a fairly high dose of clemastine, 5.36 milligrams twice daily. The problem is taking that morning dose could be quite sedating and could be be very unpleasant. It was a short trial, only 150 days, only 50 people. So it's really hard to demonstrate clinical benefits. They had a crossover design, meaning if you originally got randomized to the placebo, you later got the treatment. They weren't able to demonstrate any real benefits, but they studied function of the optic nerve. This study was done in people with optic neuritis, injury to the optic nerve due to multiple sclerosis, and they studied an electrophysiologic test called visual evoked potentials, and they were able to demonstrate information through the optic nerve could transmit faster by 1.7 milliseconds in the affected eyes. So it did something electrophysiologically in humans with MS. Does it actually have any real proven clinical benefits? This, to this day, remains unknown. And perhaps continuing on the clemastine path isn't the right idea. It seems to have a modest effect in preliminary studies, and it has unpleasant side effects, and so they developed something new. And so for the remainder of this presentation, I'll focus on this publication talking about PIPE 307, a novel remyelinating agent. And two of the authors are, in fact, Dr. Green and Dr. Chan. And it has several advantages over clemastine. First, it's highly selective. It only targets the M1 receptor. It isn't an antihistamine and shouldn't be sedating. And they found out that the M1 muscarinic receptor, rather than other muscarinic receptors, seems to be important in remyelination. It's orally bioavailable, meaning that it's readily absorbed in the gastrointestinal tract, can be taken as a pill, and it's brain penetrant. It gets into the central nervous system, and they did various assays to see if it can have other off-target interactions with different receptors, and it seems to have relatively few of these effects, so it could have relatively few side effects aside from side effects related to the M1 muscarinic receptor. They did some other studies just to prove the importance of the M1 receptor within oligodendrocytes. This is a fluorescent stain of oligodendrocytes in rat brain, in this case rat hippocampus, and you can see the stain for the M1 receptor shows abundant fluorescence, showing that it is within these cells. It's also in the oligodendrocyte precursor cells, and it's particularly abundant within active lesions. You can see in people without MS and in inactive MS lesions, the OPCs with the M1 receptor are there, but they shoot up in active lesions, suggesting that may be where a lot of the remyelination is taking place within active multiple sclerosis plaques. So there's damage, but also regeneration. Now we move to the actual effect of PIPE 307. This is cell culture, oligodendrocyte precursor cells grown in a media, either the vehicle or placebo on the left and PIPE 307 on the right, and you can see the fluorescent staining of the oligodendrocytes shows that with PIPE 307 there's differentiation into mature oligodendrocytes with extensive cellular processes. Here is a study on brain slices, not in a live organism, using the drug lysolecithin. This is a drug which can induce demyelination. So on the left is the vehicle or placebo. These slices did not receive lysolecithin. You can see in the myelin basic protein stain, there's abundant myelin, fluorescent green. They also did a stain on Casper. This targets the nodes of Ranvier, the natural gaps between myelin segment, and you can see these well-formed nodes of Ranvier. In the middle is the brain slice treated with lysolecithin. You can see there's a loss of myelin. It appears much darker, and there's essentially complete destruction and scattering of Casper because there are really no well-formed nodes of Ranvier. On the right is the brain slice treated with lysolecithin, but also given the drug PIPE 307, and there's more preservation of the myelin and the nodes of Ranvier. It's not normal, but it's much closer than the brain slice without the drug. They also showed benefits in human brain slices. These are just brain slices, obviously not from living humans, and they looked at vehicle, placebo versus clemastine versus PIPE 307, and they're looking at the concentration of oligodendrocytes, and you can see it was the least with the placebo, an intermediate amount with clemastine, and the most with PIPE 307, suggesting that PIPE 307 is in fact more potent and maybe in advance on the older drug clemastine in terms of its remyelinating effect. What about in actual living animals? This is a study on MOG-EAE. This is a form of experimental autoimmune encephalomyelitis where they give the rats this protein MOG, myelin oligodendrocyte glycoprotein, which incites the immune system to attack myelin. And there's the vehicle, the dark circle, or placebo. They have the most disability on top. Those getting lower dose of pipe 307, 3 milligrams per kilogram, had an intermediate amount of disability, and those getting the higher concentration, 30 milligrams per kilogram, had the least disability, though the effect is not huge. On the bottom are rats that were not treated with the MOG protein, so they did not acquire disabilities. So the effect is not massive, but there's a clear statistically significant benefit in animals. But what about humans? Well, they have a completed phase 1 study. This is a tiny study just with healthy volunteers, so not even people with multiple sclerosis, and they were just looking at the safety of the drug. Some people with MS can be very sensitive to anti-muscarinic receptor blockers. They can actually have cognitive side effects. But they found that at doses that they thought were good enough, that would be the equivalent dose necessary to achieve 80% saturation of the M1 receptor of the brain, there was no measured negative effect on cognitive function, at least in healthy people, people without MS. What about people with MS? We don't know yet. But we may find out soon. This is the VISTA trial, an actively recruiting trial in relapsing remitting multiple sclerosis. They're looking for 168 participants. It's going to be 1-to-1-to-1 randomization, 2 different doses of pipe 307, dose A and dose B. It doesn't say what the doses are on the clinicaltrials.gov website, and placebo for a 30-week study. So you have a 2 in 3 chance to get at least 1 dose of the drug. The outcomes are the MS functional composite, the low contrast letter acuity, a measure of visual function, time 25-foot walk, how fast you can walk 25 feet, the 9-hole peg test, a measure of upper extremity function, and the symbol digit modalities test, a measure of cognitive function, along with MRI scans and blood neurofilament light chain, a marker of central nervous system damage, and we'll see what the results show. And I gotta say, I'm excited. This is really neat. Now, some of these things don't pan out. Not everything that works in animals works in humans, and the effect in the EAE study wasn't that large, so I wouldn't expect this would lead to a total reversal of all disability in everyone with MS or anything like that. That's not a reasonable expectation, but this could be somewhat effective, and any even modestly effective remyelinating agent, if the drug itself, would be welcome news to the community of people with multiple sclerosis. Of course. Another thing I want to point out is this is a greatly abbreviated presentation. You can read the full article in the notes below. There's a ton of research, a ton of time and effort and sacrifice that went into this. So full credit to the researchers, including the many that I did not mention.
Dr. Bieber mentioned the clinical trial that's going on right now. It's recruiting. And so I thought I'd take a quick look out here with you on the clinicaltrials.gov website. I searched multiple sclerosis and pipe 307, and here's what I found. 3 studies, and the first one looks like it was looking at a slightly different thing, but this third one down here, skipping down here, this was the completed phase 1 study that was looking at safety and tolerability. So they were using healthy volunteers here. They weren't using people with multiple sclerosis. They just wanted to know if this was going to be safe, and Dr. Bieber mentioned that. The trial that's recruiting right now is this one here, study to evaluate the safety and efficacy of pipe 307 in subjects with relapsing remitting multiple sclerosis. So it's starting with relapsing MS rather than progressive MS, I think because, again, the time frames are more manageable within a clinical trial setting. Well, let's go ahead. We'll click on this. It's probably going to be relevant for many of you because many of you probably do have relapsing MS at this point. Well, I will put the link below, of course, but for here I just wanted to have you see the locations where they are recruiting. And as you can see here, there's contacts for the study. You can get a hold of one of these 2 folks if you want to be a part of this study. And here are the locations. They're all in the United States, unfortunately, for those of you who are not in the United States and can't easily get here. But within the United States, there's a number of different locations. You got Arizona, California, Colorado, Florida, Georgia, Indiana, Kansas, Massachusetts, Michigan, Missouri, New Mexico, New York, North Carolina, Oklahoma, Tennessee, Texas, and the state of Washington even had some. So if I were inclined to join in this clinical trial, there are some right almost in my own backyard. But since I am not in relapsing MS, I will not be taking part in this clinical trial. However, it's pretty exciting. I think you can tell Dr. Bieber's pretty excited. So if you get a chance to participate, you might seriously want to think about it. I went out looking to find some actual videos of the principal investigators, because I always think it's a good idea when you get to know about a certain technology. It's nice to know something about the human beings who are behind this whole thing. Dr. Bieber mentioned a couple of the researchers that he is personally acquainted with and has known for quite a long time and thinks very highly of, Dr. Chan and Dr. Green. So I am going to play a couple of short videos. The first one is from Dr. Chan, and the second one is from Dr. Green. Both of these clips are pretty old. I'll put the dates on them, but you might remember Dr. Bieber said that this research has been years in the making.
We know so little about repair and remyelination. No trial has really been done. There are no therapeutics for repair. So this is the quickest way in which we can actually bring something to the table. As science moves more and more interdisciplinary, MS research will do the same. It's going to provide new technologies and new advances for us to make the discoveries to contribute to MS. Most people would think that when we do experiments, what we want to do is confirm our ideas, our preconceived ideas, the hypotheses that we have come up with. But day to day, the thing that inspires me are these aha moments that we have, these discoveries, unexpected discoveries, things that change our hypotheses, the way we think. When I think about research, the real challenge, though, is to understand chronic and progressive MS, understanding the component of neurodegeneration that occurs and how we can stop that. So I would think that the most promising avenue in MS research right now are trying to determine whether remyelination can prevent the degeneration that's associated with progression and chronic disability. I think preventing this progression is going to change the quality of life that MS patients will have. So in my view, this is the most promising area of research. Persistence, perseverance, these are qualities that we have to have. And I'm a very impatient person. While I'm trying to be more patient, sometimes I wonder that if I was more patient, would I be less effective in doing research? This is a very exciting time in terms of MS research. I can see progress everywhere.
So, I mean, it's been known for a period of a better part of at least 2 decades that there's a unique population of cells that makes up probably about 5% of the cells in the adult human central nervous system that can turn into oligodendrocytes. So, just as a quick refresher for anybody who doesn't remember this, oligodendrocytes are the cells that make myelin. They wrap axons, and it's only the terminally differentiated oligodendrocyte, so the cell at its full maturation, that can make myelin and ensheath axons, and that's necessary for the maintenance of or for the restoration of saltatory conduction. So rapid, fast conduction of action potentials through the central nervous system is dependent upon the presence of normal myelin architecture. Target in the disease is myelin. How do we restore that? How do we bring oligodendrocytes back? The OPCs are evident. They're found tiled throughout the brain. They're tiled throughout the brain both in normal health and in disease. And again, they make up 5% of the cells of the adult central nervous system at least. So those cells are there. How do we get them to do what they should otherwise be doing, which is after demyelination happens, recovering and restoring that myelin. If we took an animal and we demyelinate the animal either chemically by something that dissolves or in a relatively targeted way dissolves or damages myelin, or we induce an inflammatory response that targets myelin, you will see some remyelination occur in a period of just a few weeks. And in fact, with the chemical demyelination models where the kinetics are really well understood, 2 to 4 weeks after the demyelination happens, depending on the animal model and the age of the animal, you will see pretty robust remyelination. So why doesn't that happen in humans in disease, in MS, is not well understood. But what we wanted to get at for therapeutics, and the reason therapeutics are showing up right now, is the capacity to screen drugs that are capable of permitting or forcing those OPCs to differentiate. That's the new area of development. So that screening methodology that identified new drugs in whole new areas of biology has matured in the last 5 years or so, and that's what's really led to identification of drugs and then the first drugs being tested in people. So I'm here, I have biases here for sure, because that's actually what my research focuses on and my laboratory focuses on, and I've worked closely in collaboration with another scientist, Jonah Chan, who's a myelin biologist, and we work to identify pathways that would be attractive and molecules that would be attractive, and then have worked to validate them, and in fact did the first successful human clinical trial in patients with a chronic lesion, trying to see could we remyelinate in that setting. So, just as a full disclosure, I have an absolute and unquestionable bias in that regard. And a secondary bias that I think would be important for clinicians to understand is that because I've worked in that space, I've provided some counseling and advice to companies that are specifically targeting that approach. So, and I have particular opinions about approaches that will work. My strong opinion is that a small molecule approach is much more likely to be successful than an antibody-mediated approach. So some people have postulated the use of antibodies because of their specificity, which is an advantage of antibody approaches over small molecules, but their negative is the target is in the central nervous system, and antibodies are huge and don't get into the central nervous system via the blood-brain barrier very easily, and would have to be given, and in fact in clinical trials have been given in extraordinarily high doses in order to be able to get enough of them into the central nervous system to hopefully have some biological effect. That's not an optimal setting. Antibodies work well as immunomodulatory agents because the target is largely in the periphery, is largely in circulation. Trying to get those drugs into the central nervous system is a challenge. So small molecules, I think, is really the way to go. And then the thing with small molecules is you have to know what's your target receptor so you can develop drugs that are selective for that target receptor as much as possible. And that's another important area that I think that's where the exciting area of biology is going on. People have suggestive data about particular pathways. I think a few of them are attractive. I happen to think a few are somewhat more attractive than others, but without, that again revolves around my own biases about things that I've been working on investigating, but working on what are the actual targets that might be capable of encouraging OPCs to turn into oligodendrocytes. That molecular exploration is ongoing and has led to understanding or identification of a whole, understanding is probably too strong a word, it's really identification of whole new pathways in biology. The understanding is going to come when we ultimately are able to draw those things together, and I think that will be really important for the development of the therapeutics, which is starting but in its earliest stages.
Wow. Okay, there you go. Yet another set of researchers who are looking at yet another method for remyelinating our frazzled nerves. And you know what? The more the merrier is kind of what I'm thinking. As Dr. Bieber says, it may not end up being the one that we use and that gets adopted, but it sure looks good. And I think they're on the right track. And I like the fact that it seems like it's pretty safe. That's always a concern for me, especially given that what I have, I don't want to lose. I think we all probably feel that way. I'm not risk averse exactly, but I'm not a big risk taker either. You're never going to find me volunteering to be the first person on the block to take a new medicine. But at the same time, I don't want to be the last one either. And I know this one is looking specifically at relapsing MS, so those of us with progressive are just going to have to be patient. But as we've talked about in other videos, there are other teams that are working on remyelination in progressive MS. This is really a hot topic. ECTRIMS is coming up in another couple of weeks, and I'm very curious to see whose research they're going to be highlighting and what they're going to have to say on the subject of remyelination. Let me know in the comments if the enthusiasm that you saw with Dr. Bieber and his research colleagues is contagious for you. Has it caught fire for you too? Are you looking forward to this? Are you excited about it? What about that clinical trial? Are you thinking about that? I'd love to know, so please do let me know. But that's all I have, so until my next video, please do take really good care of yourself so that you're in good shape for when these things actually hit prime time and we can take advantage of them.